Safety of the system is one of those recurring questions, and we've talked about it already a couple of times tonight. The My Health Record system is based on the same system that runs the tax department, which runs Centrelink, which runs Medicare. It's the same computer system that hosts it all. That's why you get in through MyGov, because it's the same. So realistically, as Rob described before, identity theft can be done now, nothing to do with My Health Record, if it can be done now, through our tax records or our Medicare records. You don't need My Health Record to be the leak. So breaches like that are really in the same class. Now, there's been very small, as far as I know, virtually no breaches of the tax department or the Medicare system. So why should we be thinking that there will be a breach of My Health Record? But we need to keep an open mind to that, because of course there inevitably will be. That's the nature of computing and data. So how do we manage the risks of data breach, and how do we actually think about that in order to control it? The number one place for a breach to occur is actually at our local practices. So it's whether we use shared passwords, whether we don't have screensavers so the computers stay on when we're not in the room, when we have unauthorised people accessing our computer systems and hence potentially My Health Record. And that's probably where the biggest potential risk is for getting through into the system. So passwords, how often do we change our passwords? How often do we make the passwords really difficult to crack? That sort of stuff. So it talks about the culture of security within the practice, of how secure the patient's data and the practice data is within the practice. So that's the firewall of the practice, the codes, the level of the backup repetitions, that sort of stuff. That's the backroom stuff within the practice that we as clinicians don't really care about, to be perfectly frank, but it's so important. The system itself, as we've chatted about, is based on the same system that MyGov is. So it's part of the government data set that is very, very securely protected. It's stored in Australia. This is not stored overseas. It's not stored in the cloud, whatever that means, in some foreign server. It's all stored in servers in Australia. So if there's some break of some cable, some telecommunication cable in the Pacific Ocean, that won't disconnect our tax information and it won't disconnect our My Health Records. And there's a constant vigilance towards security by the system. So there's a team of 25-year-old hackers who are constantly trying to break into the system through various ways, and they actually haven't been able to do that. And then the third level of risk mitigation is through the governance of the system, and there are tremendous penalties for breaching the system. So the fines are in the hundreds of thousands of dollars and possible jail sentences for breaching this system. So it's really very, very substantial. The OAIC, which is I can't remember what it stands for, but it's the Information Security Office, is constantly supervising this sort of stuff. And of course, the Medical Indemnity Office, the organisations are involved in this. They've been involved right from the beginning. So whether it's Avant or whichever company you happen to be with, they've been well involved and have declared, relative support for the system, but with minimal or no real onus and responsibility on us. And that's what the particular episode I mean is, if there's a document sitting in My Health Record that is obviously important, do we have a responsibility to look at that? And therefore, can we be sued for not looking at it? And the answer is no. Okay, you can't be, because there's no notification system. We can't accept responsibility for that document by just sitting in My Health Record. the data is important. So data is something that we sort of talk about and think about, but we don't really use. We're clinicians and we're not really using the data ourselves. We're not statisticians, we're not data managers. But data is very important and valuable to lots of different organisations. There's a lot of predictive value in data of how we do things, what patients what disease states and medications are being used, the trends that are happening over periods of time when it's re-looked at. So data itself is very important. So clearly My Health Record, just like the PBS and just like the MBS, is collecting data all the time as we use it. So the question is, what will happen to the data? Can it be used in the future? So as a general rule, the college is quite supportive of use of the data for high intellect purposes, for academic research, or for development of clinical decision support packages, right? So in other words, computer programs that help us decide what the best form of treatment is for our patients. The government's declared that there won't be any secondary use of data. That's what secondary use of data means, that there's a use beyond initially with your patient, but there's the secondary use, the use after that as a population. So the government's declared there won't be any secondary use of the data for a couple of years, till 2020. And even after that, there's going to be very strict guidelines on how it's going to be used. So insurance companies will not get access to the data. Neither will other sort of sinister organisations, right, like drug companies. So pharmaceutical companies won't get access and insurance companies won't get access. And there's certainly been a lot of talk about what's happening to the data over the last few months with the opt-out period, right, starting. So that's you know, there's been these side conversations with a lot of conspiracy theories being developed, that most of which are completely unfounded in reality. So the key messages for tonight, I've got to read it from up here now, hang on, which we can see there is, first of all, that the consumers or the patients and the providers, the doctors and the other healthcare providers, have really come to a realisation that the use of having healthcare information in a digital form and accessible with the patient is actually valuable. So that's probably the key message, isn't it? That the information that is from My Health Record stays with the patient. So wherever the patient goes, the clinician who's treating the patient will have access to that information so he can build on it, instead of going backwards all the time and starting again and again and again. So it's the mistakes, the allergies, etc., as well as building on the information. That everybody will have the turnover from an opt-in to an opt-out means that instead of previously with opt-in, what that meant is if you wanted a My Health Record, you had to sign a document that would then create the record. The record would be created for you. With opt-out, as it's moving to, everybody will get a record unless you decide not to have one. So it's the reversal of the process. So that's perhaps not particularly widely understood by both clinicians and the patients themselves. So the question is where to from here? So I'd suggest certainly that reading the red booklet that you've got tonight's a good start. Just have a flick through there. Speak to your practice managers to make sure that your system at your local practice is engaged and you have the appropriate follow the security coding stuff. Have a look on the Digital Health Agency website as well as the college website to get more information and really go from there and give it a go. Have a look at, get a patient who's got a My Health Record and have a look inside, because there's a whole lot of information there that's freely available basically about our patients for their benefit, and it makes our job a little bit easier.